Okay, so welcome to today's lesson, and today we're going to look at prematurity in pediatrics. So when it comes to prematurity, we can define it as we can define prematurity as this is a pediatric condition in which the baby is born after 28 weeks of gestation, but before 37 complete weeks, calculated from the first day of the last menstrual period, characterized by large head in proportion to the body, widely spaced sutures, and small chest less than 33 centimeters. So that is the complete definition of prematurity. You remember, I've always said in your definition, you need to give us an insight where that condition is coming from. And in this case, I've mentioned this condition is a pediatric condition. If you want, you can say this is a neonatal condition. It will still be accepted. Then what is prematurity all about? I've mentioned to say this is a condition where the child is born after 28 weeks, but before 37 weeks of gestation age, calculated from the first day of the last normal menstrual period. And apart from that, you need to give a characteristic. Since prematurity has no specific cause, so we cannot mention a cause in the definition. But in terms of characteristic, you can put 2 or 3. And I've said the characteristic, one of the things that would be a clinical manifestation in prematurity is a large head in proportion to the body, because by then the body would have not developed, the body tissue would have not developed to match the head. And then the other characteristic is widely spaced sutures. So in the head, when the baby is born, there are fontanelles, and you have the sagittal suture on the middle of the head, you have the coronal suture, you have the lambdoidal suture. So you realize that those sutures, which are the bones which overlap during delivery of the baby, they are too widely spaced from each other, which should indicate that this baby is a premature child. Apart from that, the chest is going to be less than 33 centimeters, which is going to be smaller than normal. And the normal chest should be at least between 33 to 35. But in this case, you'll find that the chest is very small. So that is how you should define prematurity, and you should always give characteristics once you define a particular condition. So from here we can move on to characteristics or the predisposing factors of prematurity. So when it comes to the predisposing factors, so the predisposing factors, we are going to talk about them in groups. So we'll start with maternal related factors. So in terms of predisposing factors, we'll talk about them in groups, and I'll start with maternal related factors. So when it comes to maternal related factors, the first one is cervical incompetence. So in terms of cervical incompetence, some women have a cervix which cannot sustain pregnancy, whereby as the pregnancy goes, the cervix opens up instead of opening up after 9 months or at 9 months, but it opens up too early, expelling the fetus. Then some conditions such as some maternal illnesses such as TB may result in a woman having or delivering earlier than normal. Diabetics mellitus, malaria, anemia, this condition may result in premature birth of a child. Let's pick an example in malaria. Malaria, there is increased hemolysis of red blood cells. So sometimes it may happen that the red blood cells reduce in number, reducing the oxygen supply to the baby. As a result, the body won't be able to supply enough blood both to the mother and the baby, and then it may decide to expel the child because there is not enough oxygen and blood reaching the fetus. Then sometimes also the other maternal related factor is age. So outside optimum childbearing age, such as below 18 years or above 35 years, these may predispose a woman to having a premature child. And in these both cases, it is about this individual having a uterus which cannot sustain pregnancy. Of course, we have seen women bearing children below the age of 18 and also above age of 35. But we are saying this may happen, but they have a higher chance of having a premature child because their uterus is not fully developed to sustain properly a pregnancy. Then also preeclampsia is another maternal-related factor, and this is hypertension in pregnancy. So in hypertension, remember what happens is that even though there is increased blood pressure, but the volume of blood being supplied to the rest of the body is less. Therefore, as there is less blood supply to the rest of the body, there will be also less blood supply and oxygen delivery to the fetus. Therefore, this may result in premature birth of a child because it is no longer receiving enough oxygen. Then the other predisposing factors, I'll talk about them under the heading fetal-related factors. So those were maternal-related factors. Then the next one is fetal-related factors. So the first one, in terms of fetal-related factors, we can talk about multiple pregnancy. So when it comes to multiple pregnancy, here it could be because the body cannot provide enough nutrients and also oxygen to be able to sustain the number of fetuses that are present in the womb. Then the other thing under multiple pregnancy is where there is lack of spacing. So where there's lack of spacing, it means this woman gives no chance for the involution of the uterus to take place so that it can sustain a next pregnancy or next fetus. Therefore, if the child has there is lack of spacing, meaning they will be having a child with a uterus which is not yet fully prepared to sustain that particular fetus. Therefore, it may result in expelling of that fetus early before term. Then there are also other conditions such as intrauterine growth retardation. So when it comes to intrauterine growth retardation, here basically there is so here in intrauterine growth retardation, you'll find that there are some condition which makes the baby grow slow as compared to the rate at which this child should grow. So there are conditions which predispose the child or makes the child grow slow as compared to the rate at which this child should grow. Therefore, you do your examination and find to say, when you check the height of fundus and then you do other scans, you find that the baby is maybe not growing as compared to the time it has stayed in the womb. Therefore, you might find that the baby may even not have proper organs and other structures. Maybe the limbs are not formed and other things are not yet fully formed. Then the body may decide to expel that fetus because it is not taking shape as a normal human being or fetus should take shape. Then multiparity. So multiparity is another predisposing factor. Then also the other fetal-related factor that we can talk about is rhesus factor incompatibility. So where you have different proteins between the mother and the fetus, and this could come from both parents, where you are married as a husband and wife, but you have different rhesus proteins in your blood group. This may mean that the baby is going to inherit both different proteins of rhesus, making it difficult for that baby to survive because those two things will start attacking themselves, killing each other. As a result, also killing the red blood cells. And then because you have two different sets of red blood cells having two different sets of proteins, this may make it difficult for this fetus to even survive in the pregnancy, making it to be expelled early. So those are some of the fetal-related factors. Some other predisposing factors, I'll talk about them under the heading placenta-related factors. So when it comes to placenta-related factors, here we can talk about placenta insufficiency. So in terms of placenta insufficiency, some women have a placenta which is unable to sustain pregnancy. As a result, there is early expulsion of the fetus. So that is placenta insufficiency. Then the other one is antepartum hemorrhage. So antepartum hemorrhage can include maybe placenta abruptio or even placenta previa. So this may result in a woman hemorrhaging severely before they are ready to deliver that child. And when a woman loses a lot of blood and which cannot sufficiently supply the fetus, meaning the fetus will be expelled so that the woman has enough blood for herself. So that's how these conditions may predispose a woman to prematurity. Then the other causes could be related to drugs such as alcohol, narcotics, and also drugs such as quinine. These drugs, they may predispose a woman to prematurity. Then also socioeconomic status. So where there is low socioeconomic status, meaning this woman is going to be eating foods which are not nutritious. And if the child is not receiving enough nutrients, meaning the fetus won't be growing. And if it can't grow as compared to the weeks it has stayed in the womb, it will be expelled, meaning this can lead to prematurity. The other predisposing factor, like you can see, is teenage pregnancy. So these are just other causes. They are not falling under placenta-related factors, but these are just other predisposing factors. Teenage pregnancies in teenagers, the uterus is not ready or developed enough to sustain pregnancy. Other factors could be trauma. So while you're in an accident, you have trauma to the abdomen. This could cause injury to the abdomen or the uterus, causing expulsion of the fetus. So these are some of the predisposing factors of prematurity. Then from here now we can move on to the characteristics or the clinical manifestations of prematurity. So when it comes to prematurity, preterm babies are immature and they are not able to adapt to extra uterine life. Therefore, the characteristics may be related to gestational age. So when it comes to the characteristics, we'll look at them for also in groups. We'll start with the head. Mainly the head, like I said in the definition, the head is larger in proportion to as compared to the body with a triangular face. Apart from that, the head will also have a pointed chin and they also have a worried expression. So in terms of the head, that is the characteristics that you are going to see on a premature child or a clinical manifestation. Apart from that, I talked of sutures in my definition. Sutures and fontanelles will be widely separated and the skull bones are very soft. So when it comes to the fontanelles, remember when you're doing a physical examination of a newborn, you're going to check the sutures, how they are aligned, and also the fontanelles. The fontanelles, if they are bulging, meaning there's presence of infection, indicating to say inflammation is taking place, and this is resulting in this bulging of the fontanelle. A sunken fontanelle indicates that there is dehydration, but in cases where there is prematurity, you are going to see widely spaced fontanelles and also sutures. And the skull bone is also very soft and brittle, and this will indicate to say this child is a premature child. The other characteristic is in relation to the skin. So when it comes to the skin, it is very thin and it appears brick red due to absence of subcutaneous fat. Apart from that, the surface veins are also absent, and the skin is covered by a variety of soft hair, and this hair that covers the entire skin is called lanugo. So when you deliver a child and you see this child has hair on the entire body, that hair is called lanugo, and it is an indication to say this baby is a premature, because this hair should normally drop off before they are around 34, between 34 to 37 weeks, so that hair only remains in regions or areas where hair should remain. Then when it comes to the other characteristics in relation to the upper and lower limbs. So mostly these limbs, they are thin and the nails are very soft. The palm and also the palm are not well formed. So you find that the palms are very soft and not properly formed sometimes, depending on the age when this child was delivered. Then the other characteristic is in relation to the chest. The chest normally is small and narrow, less than 33 centimeters. And the breast tissue may not even be palpable or not properly formed, meaning this child is a premature child. And then the other characteristic is on the abdomen. So mainly the abdomen, you'll find that the abdomen is large and often distended, and the umbilicus appear to be low set. Then the genitalia, in terms of the genitalia, mainly the genitalia is small, and the female labia majora does not even cover the labia minora. So you may realize that as you are checking the private part, you may find to say that maybe the labia majora is not even formed, which in normal cases you need to have a labia majora, which is the mitre lips covering the minor lips, but you only see the minor lips, which is the labia minora. So the labia minoras appears prominent. Then in the male, if it's a male baby, a premature male baby, you may realize that the testes may not even have descended into the scrotum. Then apart from that, the scrotum will have very few rugae. So rugae, this is just the structure or the appearance rather of the scrotum. It is not so smooth, it appears like it is wrinkled. So those are rugae, and that is the normal. But in a premature, you may find that there are no rugae. Then the other thing is that the muscle tone is also very poor, and the baby also appears drowsy, and also the suckling reflex is poor, or it may even be entirely absent. So those are some of the characteristics of a premature baby, and I've grouped them so you may be asked to mention the characteristics or clinical manifestation in groups, meaning that's how they should be mentioned. And if they have said state, meaning you need to give reasons to your answers. Unless where you have just been told to list, meaning you just list without any explanation. When it comes to nursing management of prematurity, here, prematurity is an emergency condition, and the only cardinal management here is nursing management. So you may have you may put your aims such as to initiate and maintain respiration. So you may have your aims such as to initiate and also maintain respiration, to prevent hypothermia, to prevent infections, to prevent hypoglycemia. So the cardinal thing on prematurity is that you need to resuscitate this child and maintain proper respirations. So after having those 4 M's, which will give you the 4 marks out of the 50 marks for management, you will now go to resuscitation. The baby needs to be resuscitated before you do anything else. So you write your heading, resuscitation. Remember, the key to passing the management part is having headings, not just writing answers anyhow. But when you have headings, they are going to carry marks because it will be easy to follow through your management. Then, so when you write patient resuscitation or resuscitation of the child, you are going to start with the airway. On the airway, you need to do suctioning, Apart from suctioning, you can also reposition the baby to promote free flow of secretions. Then apart from that, you can go to breathing. In terms of breathing, you need to give 1 to 2 liters of oxygen per minute. This is going to promote tissue perfusion and delivery of oxygen to body tissue. Then apart from that, you don't talk about nursing the child in a well-ventilated environment. You're going to predispose the child to cold, and the cold hypothermia can easily kill a child because it will result in less production of surfactant, causing the lungs hard for them to expand and relax to expel carbon dioxide. So you don't nurse a child in a well-ventilated environment. That's why pediatric units are always warm. Then you can go to circulation. In circulation, you need to give fluids. You can give normal saline. You can also give dextrose 5%. This is so dextrose is for energy, and then normal saline as a blood expander. So you can give all those fluids to this child. Then from there, you're going to have headings: prevention of hypothermia, meaning talk about nursing this child in a warm environment. Also, you can talk about nursing this child on a pre-warmed resuscitator to prevent hypothermia, covering the baby in enough linen, and also providing warm linen to this child, and avoiding exposure, exposing the child to direct air, such as closing windows if they are available, and all those things that can make the child go into hypothermia. After prevention of hypothermia, we'll go to another heading, which is prevention of infection. So in terms of prevention of infection, you need to nurse the child in a clean environment. You need to do damp dusting. You need to maintain aseptic techniques, and also limit access or visitation to this child so that the child does not get infections from other individuals. Then on prevention of hypoglycemia, this is important because this is just a newborn baby, and then they may have a liver which is not able to process glycogen and other carbohydrates into glucose properly. So you need to prevent hypoglycemia. And on prevention of hypoglycemia, meaning you need to initiate feeds. If the baby is able to suck, the presence of suckling reflex, meaning you breastfeed the child immediately. If the child is unable to breastfeed, you can give dextrose 5% using a syringe through the mouth, or you can give it through an IV line. So on prevention of hypoglycemia, you can talk about those interventions. Then from there, you can also talk about the other heading. So those are enough in immediate care. You can even move on now to subsequent care or management. So in terms of subsequent care, you can just move on now to observation. So you can do your OBS, and as usual on your OBS, talk about the temperature, pulse, respiration as your first points, because these are going to be used for baseline information. So temperature to monitor hypothermia and rule out infection, respiration to detect any respiratory difficulties, of which if you find to say the respirations are between 30 to 60, meaning this child is in respiratory distress. Then in terms of the heart rate, this is also to monitor cardiac function, and the normal heart rate should be between 120 rather to 160 beats per minute. Then you also observe maybe for skin color in order to detect any cyanosis. Also, you can observe for signs of jaundice, bowel, and also bladder function. You can check daily weight gain, which should be between 100 grams to 150 grams per week. You can also check or observe the feeding pattern. So all these points, you can put them under observation. From there, you can move on to maybe nutrition. So you can move on to nutrition in terms of nutrition, you say early feeds are important, meaning feeding of the baby is very important. Here you can breastfeed the child if it's able to breastfeed. If unable, you say I will insert an nasogastric tube and feed by cup. You can even give dextrose 10% or 5% using an IV, and you can also give expressed breast milk through an NG tube. So those are the points that you can talk about on feeding. So you even say I'll give small frequent feeds and ensure that there's no overfeed or overload, and I'll record all feeds on the feeds chart. So these are done to prevent overload. So you can talk about all those points on nutrition. When it comes to hygiene, so you will have your heading, another heading as hygiene, and ensure that during your exam you at least have more than 10 headings in your management. It will give you a good chance of getting good marks out of the 50 marks. So far I've talked about 8 headings. So you can talk about also hygiene. In terms of hygiene, you talk about doing top and tail cord care to prevent infection or infection prevention measures. You should do all infection prevention measures such as changing soiled linen, nappies for comfort, and I'll also allow the mother to participate in the care of the baby to promote baby-mother bonding. So you can talk about all those points in your hygiene. Also, you can give psychological care to the mother because the mother may not know why you are nursing their child in that manner. So giving them psychological care about explaining the condition, what is being done to the child, and the reason why things are being done in that manner will help gain cooperation and also give reduce anxiety to the mother. Then when it comes to the last one, so the last heading should be about elimination. In terms of elimination, you're going to observe the output in terms of the urine and also the feces or the meconium to rule out dehydration or intestinal obstruction. So you check the urine output, the volume as compared to the input, and also the meconium, if it's being formed or it's diarrhea or other things. This will help you know whether there is a obstruction or there is no obstruction or there is overload of feeds or fluids. So you need to also monitor the elimination of the child. So in terms of management, that's where you end. But if your last question talks about IE, doesn't talk about IEC, maybe it talks about complications, meaning your last heading should even be about IEC only, discharge. But if your last question on your management, on your scenario rather, talks about IEC, meaning IEC shouldn't be part of your management. So on IEC, the points on IEC that you can give here, you can educate the mother on the importance of hand washing and infection prevention. You can also educate the mother on the danger signs such as excessive vomiting, fever, fits, abdominal distension, all those things. You can also stress the importance of keeping the baby warm. You can explain the importance of feeding the baby regularly. Apart from that, you can also explain to the mother the importance of immunization and children's clinic, and also talk about review dates, and if any complications arises, they need to come back to the nearest facility or the same facility. So those things can be talked about. So in terms of management, those are the things that you can talk about, and IEC, those are the things that you can also talk about. Then the other thing is in terms of complications of prematurity. So prematurity The first complication is that it can result in jaundice, and this is because there is immature liver, which may lead to failure of conjugation of bilirubin, which may accumulate in the blood stream. Apart from that, it may also result in cerebral hemorrhage as a complication. This is because the fetal skull is very fragile and does not offer the needed protection to the brain. Therefore, it may also result in vitamin K deficiency, causing the child to hemorrhage easily. Then the other complication is retrorental fibroplasia. So this condition is mainly characterized by proliferative changes in the retinal vessels, which may be followed by hemorrhage and also peripheral separation of the retina. Then apart from that, it may be caused by excessive oxygen concentration. This is the reason why you don't give overdose of oxygen. Oxygen is good to the body, but if you give it overdose, it may cause the retrorental fibroplasia, causing damage to the retina, meaning this child becomes blind. So you don't just give oxygen. Remember, in a child, you give 1 to 2 liters per minute, not like in an adult. So the other complication is anemia, and this is due to low iron stores as a result of short intrauterine period. Then the other complication is respiratory distress syndrome, and this is the major cause of prematurity. So in this condition, there is failure to maintain respirations due to lack of pulmonary surfactant, and this causes the lungs to collapse every after successful breath. The other complication that may arise is infection. So this is due to premature baby born before the term, and the baby does not have the immune system fully developed to be able to prevent it from infections. So those are some of the complications that may be seen in prematurity. So those are some of the complications that may be seen in prematurity. So that's how you manage the condition, and those are some of the complications that you may see in prematurity. Okay, so we'll end here for today's lesson in prematurity. If you have any questions, you can leave a comment and then we'll be able to attend to the questions. Thank you for taking time to go through this tutorial or lesson. We'll meet next time with another condition.